If you wake up tired after 60, despite enough time in bed, sleep apnea is one possible reason worth checking now. Sleep apnea can repeatedly interrupt breathing during sleep, often without the sleeper realizing it is happening. Loud snoring, breathing pauses, gasping, morning headaches, and dry mouth can all be important clues to apnea. But one symptom alone does not diagnose sleep apnea, because many common problems can cause similar complaints. After 60, the pattern can look less obvious, which is why some people blame poor sleep, fatigue, or normal aging. In this video, you will learn 6 warning signs, what they mean, and when a proper sleep evaluation makes sense. You are watching Dr. Edward, where we explain practical health information for adults over 60 in plain language. Today we are focusing on obstructive sleep apnea, the most common form, without turning symptoms into a diagnosis. This is general health education, and persistent sleep or breathing problems should be discussed with a clinician. Obstructive sleep apnea happens when the upper airway repeatedly narrows or closes during sleep for short periods. Each interruption can reduce airflow and disturb sleep, even when the person does not fully wake up or remember it. The brain may briefly increase arousal to reopen the airway, causing fragmented sleep across many hours overnight. That repeated disruption can leave someone feeling unrefreshed in the morning, even after spending enough time in bed. Warning sign number 1 is loud, frequent snoring, especially when the sound is disruptive or changes through the night. Snoring is common and does not automatically mean sleep apnea, but repeated loud snoring can raise suspicion for it. A partner may notice that the snoring becomes irregular, suddenly stops, then starts again with a louder breath or gasp. Warning sign number 2 is witnessed pauses in breathing, especially when another person sees them happen repeatedly. These pauses can be brief, but repeated episodes during sleep are more concerning than one isolated, unusual breath. If a partner describes repeated silence, followed by choking, snorting, or gasping, that pattern deserves evaluation. Warning sign number 3 is waking with gasping, choking, or a sudden sense that you need to catch your breath. Some people remember these awakenings clearly, while others only learn about them because a bed partner notices. Warning sign number 4 is waking unrefreshed or feeling unusually sleepy or fatigued during the daytime hours. Sleepiness can appear as nodding off while reading, watching television, sitting quietly, or riding as a passenger. Fatigue is broader than sleepiness, so feeling low in energy alone does not prove that sleep apnea is the cause. Warning sign number 5 is a morning headache that appears on waking and gradually improves later in the day. Morning headaches have many causes, including poor sleep, dehydration, medication effects, and other health problems. They matter more when combined with loud snoring, witnessed pauses, gasping, or persistent daytime sleepiness. Warning sign number 6 is waking with a dry mouth or sore throat, especially when nighttime mouth breathing is common. Dry mouth can also come from medicines, dehydration, or nasal blockage, so it should be interpreted in context. The strongest clue is usually not one symptom, but a recurring pattern of nighttime breathing changes and poor sleep. After 60, sleep apnea can sometimes present with insomnia, frequent nighttime urination, or unintended daytime naps. Attention or memory complaints may also appear, but these symptoms have many causes and are not specific to sleep apnea. That is why older adults should not assume every sleep problem is normal aging or that every tired morning is apnea. A clinician may consider symptoms, medical history, medications, body structure, and other conditions before testing. A sleep study can measure breathing, oxygen levels, heart rate, and sleep patterns to clarify what happens overnight. The risk of missing sleep apnea is not only feeling tired, because untreated disease is linked with broader risks. Sleep apnea is associated with high blood pressure, cardiovascular disease, stroke, and other metabolic problems. Those associations do not mean every person with apnea will develop them, or that apnea is the only possible cause. Another concern is safety when excessive sleepiness affects driving, balance, concentration, or other daily activities. Pushing through severe sleepiness with caffeine does not replace evaluation when you are struggling to stay awake. A second mistake is assuming that thin people cannot have sleep apnea because body weight is only one risk factor. A third mistake is buying treatment equipment without diagnosis, since the right therapy depends on the actual disorder. Symptoms can overlap with insomnia, heart or lung disease, medication effects, depression, and other sleep disorders. The encouraging part is that sleep apnea can be identified, and effective treatments are available for many people. Before I show you the next steps, subscribe and tap the bell for practical health guidance designed for adults over 60. If you wake tired, snore loudly, or have breathing pauses at night, stay with me through the evaluation steps ahead. After the full plan, type 1 in the comments so I know you want more practical videos about sleep health after 60. Step 1 is to ask whether your sleep feels restorative, not simply whether you spent 7 or 8 hours in bed. Notice whether you wake refreshed or whether fatigue and sleepiness continue even after what seemed like enough sleep. Step 2 is to ask a bed partner about snoring, breathing pauses, choking, gasping, or sudden changes in breathing. A partner's observations can be useful because many breathing events happen without the sleeper becoming fully aware. Step 3 is to track morning symptoms, including headache, dry mouth, sore throat, and unusual difficulty waking. Write down how often these symptoms occur so your clinician can see whether they form a repeated pattern over time. Step 4 is to notice daytime sleepiness, especially if you doze unintentionally during quiet or passive activities. If you feel sleepy while driving, treat that as a safety problem and avoid driving until the issue is addressed. Step 5 is to review alcohol, sedatives, and medicines with a clinician because they may affect nighttime breathing. Do not stop prescribed medicine on your own, but make sure your clinician knows what you take before sleep testing. Step 6 is to discuss other conditions, including heart disease, lung disease, stroke history, and chronic insomnia. Those details can influence whether a home sleep apnea test is appropriate or whether laboratory testing is preferred. A home sleep apnea test can help selected uncomplicated adults when a qualified clinician orders and interprets it. If a home test is negative, unclear, or technically inadequate, a laboratory sleep study may still be recommended. Polysomnography in a sleep laboratory provides more detailed information and remains the standard diagnostic test. Testing should answer a clinical question, not become a do-it-yourself screening habit for every older adult who snores. If sleep apnea is confirmed, treatment depends on severity, symptoms, medical conditions, anatomy, and personal needs. Positive airway pressure, including CPAP or APAP, is a common and effective treatment for obstructive sleep apnea. The device keeps the airway open during sleep by providing gentle air pressure through a properly fitted mask. Some people need time to adjust, and mask fit, dryness, pressure comfort, or nasal symptoms may require troubleshooting. Do not assume CPAP failed after one hard night, because equipment changes can make treatment easier to tolerate. For selected patients, an oral appliance may be considered, especially when it is fitted by an experienced professional. Sleep position can matter for some people, and side sleeping may reduce events when apnea is position dependent. Weight management may help when excess weight contributes, but sleep apnea can still occur in people who are not obese. Alcohol near bedtime may worsen airway collapse in some people, so intake belongs in the sleep history discussion. Smoking cessation and regular activity support overall health, but they do not replace indicated apnea therapy. Surgery or other procedures are options for selected patients when anatomy and treatment history make them appropriate. The best plan is individualized because two people with the same apnea severity may have different symptoms and needs. Older age alone does not mean treatment will fail, and many older adults can use positive airway pressure successfully. Treatment decisions should consider symptoms, function, frailty, other illnesses, and what matters most to the patient. Do not chase only one number from a sleep report, because symptoms and clinical context remain important for decisions. If treatment begins, follow-up matters. So comfort, adherence, residual symptoms, and equipment problems can be reviewed. Persistent fatigue after treatment deserves another look, because sleep apnea may not be the only reason you feel tired. Persistent insomnia, restless legs, medication effects, or mood symptoms may also need separate assessment and care. The goal is better breathing and more restorative sleep, not simply owning a machine or collecting a sleep study result. A useful next step is keeping a simple 2-week record of snoring reports, awakenings, morning symptoms, and sleepiness. Bring that record to your clinician along with a medication list and any history of heart, lung, or neurologic disease. The key message is that sleep apnea is a pattern of breathing disruption during sleep, not just a problem with snoring. Loud snoring, breathing pauses, gasping, unrefreshing sleep, morning headaches, and dry mouth deserve context together. Many people with one of these symptoms will have another explanation, which is why proper evaluation matters more. If several signs occur repeatedly, especially with daytime sleepiness, discussing sleep testing is a sensible next step. Do not wait for dramatic choking before asking for help if the nightly pattern is already affecting daily life. And do not dismiss persistent tiredness as aging when a treatable sleep disorder could be contributing to the problem. As a bonus, older adults may show less classic apnea symptoms than younger adults, so patterns can be easy to miss. Nighttime urination, insomnia, unintended naps, or cognitive complaints can add context but are not diagnostic alone. A partner's observations and a short symptom record can reveal patterns you may never notice while you are asleep. If nights include repeated breathing changes and days include persistent sleepiness, ask about a sleep evaluation. Subscribe for practical health education after 60, and prioritize safety if sleepiness makes driving or daily life hard.